Hey, Kelly. I'll start here, take the stage myself, and just say that I'm very happy that we're hosting a webinar in this topic, cranial sacral therapy, that you will expand on. And I'm happy that we're doing this before the release of the actual course about offering an introduction and a foundation to the treatment of cranial sacral therapy. So I'm glad we have the opportunity to do this for people to also pick your brain a little bit, so that it'll be interesting for me to see here as a host, as an observer. Kelly is a certified athletic trainer, a licensed massage therapist, and a certified craniosacral therapist. And I had the pleasure of meeting her in the athletic training room as a college soccer player. And I was on the men's team, but Kelly was the athletic trainer on the women's team. And Kelly has, is it 3 national championships, Kelly? So I don't know how many athletic trainers in the US can say that they have 3 NCAA championship medals, but that's pretty impressive. So that's where I had the opportunity to meet Kelly. I had the opportunity to be treated with craniosacral therapy, so I've seen the inner works of it inside my body, and how it made me feel, and how I saw the potential connection I could have with it, and how it could help me. So it really, the main effect it had on me, cranial sacral therapy, up until this point, is just has made me more curious. So I'm very excited to hear what you have to say this evening, or depending where you are in the world. So the stage is yours, Kelly. And whenever you're ready to present.
Hi, I'm Kelly Saxton. It's nice for everyone to come join me today and learn a little bit about cranial sacral therapy. I met Danny. He's our host today at Penn State. I was an athletic trainer then, and we've since reconnected, and we're releasing this full class, this full coursework later in 2024. But this will give you a good background, a quick look into the anatomy, the physiology, and a little bit of the history, and a few little treatment examples with cranial sacral therapy. I am a licensed athletic trainer, as well as certified athletic trainer, licensed massage therapist, and I have gone through the full technique certification through the Upledger Institute with cranial sacral therapy. I think it's kind of a good place to start, and all the way back to the beginning, that I grew up in a very calm and grounded family, and you have to have both of those strong attributes as a cranial therapist. You have to be very patient. This is a very slow moving modality. I then took my love for athletics into the Division I setting, and that's where I did 16 years with athletic training. And I really worked with a super high level, very healthy athletic population. I found a really great mentor that introduced me to this cranial work. And I think it's also important to note that I had a very healthy skepticism about cranial work when I was first introduced to it. It's not that cookie cutter sports medicine model where it's pain management, therapeutic exercise, and get your athlete back on the field. It's very much on the other end of the spectrum. And he was a really great mentor in pushing me, and not necessarily spoon feeding me the information, but he was a really great person to kind of guide me through this and really let me blossom with the modality. I found that I was ready to leave college athletics, and I found some licensure challenges because I wanted to continue doing cranial work. But I don't know if too many of you know much about athletic training, but a physician has to sign standing orders for an athletic trainer to practice. And I couldn't do that without a physician. And it's very hard to find a physician that will support an independent athletic trainer. So I got my license in massage and have since opened my own business. And I'd say cranial work's about 50 to 60% of what I do on a daily basis. I put some more things on there that I'm interested in, things that I'm exploring right now, or the gut-brain connection, really diving into the visceral manipulation world, as well as working with retained primitive nerve reflexes, which we're going to go over a little bit today. Looking into the history of cranial work, it's really started in the early 20th century with Dr. Sutherland, who was an osteopath. And he did some really primitive studies. One of his most primitive was looking at X-ray images of the skull, and he would take them several seconds apart and then would measure them. And he could see that there was a measurable change in the shape of the skull that was rhythmic. Later in the 1970s, Dr. Upledger, who was also an osteopath, was assisting with a spinal surgery where his job was to hold down the dura mater, which is the surrounding of the central nervous system, while another surgeon tried to scrape a plaque off of this tissue. And he found that he could not hold that dura mater still, and really started to do his own research and found Dr. Sutherland's original work, and then ran to Michigan State and started doing more cranial type maneuvers that Dr. Sutherland had started. He did a lot of research with autism. He later opened his own institute in Palm Beach Gardens, Florida. And he has, his predecessors have started teaming up with the NFL, the US military. They've put out some bigger studies that show the validity of cranial work and some other body work that institute supports. So diving right into the good stuff, if you look at the skull, when you look at a US textbook versus a European textbook, the US textbooks are almost all going to support that these suture lines are fused. And that's because they look at embalmed cadavers. When you embalm tissue, it loses the vascularity, it loses a lot of the nervous tissue, and you lose what that joint looks like as a living joint. Whereas European texts use a lot of unembalmed cadavers, and they can actually take slices of these suture lines and look at them under a microscope and see that there are Sharpie's fibers, which are collagen based, that provide a lot of support, but they also support movement. Blood vessels, nervous tissue is all in those joint lines. There's an actual measurable movement. It's in nanometers. It's very small, but it is present. The only evidence of ossification are at embryological sutures. So if you were to run your fingers across your forehead, you'll likely find a valley that goes from the top of your forehead down to your eyebrow. That's an embryological suture where your frontal bone was in more than one piece. It was in two pieces and it came together and fused in utero. So we're talking about the skull plates themselves and where those suture lines come together and they are not fused. You have little islands sometimes within those suture lines called Wormian bone, and we're not really concerned with those. I do want you to look at the infant skull versus the adult skull. There's obviously room for growth with an infant, and there's larger gaps between those islands. So it doesn't require as much force. And really some of the maneuvers that you would do with an adult, you will not do with an infant or a child because they don't have some of the bony development that an adult skull has. So if you're interested in working with kids and infants, I would highly encourage you to take a pediatric course. This would be more looking at the adult skull. Looking at the colored bones versus the white bones in the other picture, you're looking at what's called the physiological system versus the non-physiological system. And what I mean by physiological is that dura mater that surrounds the central nervous system actually blends into the periosteum of those cranial bones. You cannot dissect them apart. So that is the essence of what cranial work is. You're using these colored bones as handles to pull on the central nervous system and work that system like you would with any other type of body work, but you're manipulating the central nervous system. Your cranial bones are handles. The non-physiological system would be the facial bones because they don't have a dura mater direct connection into the periosteum. They are just as important as the physiological system. Sometimes I feel like I treat non-physiological system more than the actual cranium itself. You know, think of an example like getting hit in the face with a soccer ball. what's gonna give first are going to be those non-physiological system bones. And we're going to go over sphenoid specifically a little bit more in depth, but that's the king of the cranial system. That's the keystone. That's the one bone in which articulates everything. Every colored bone touches that sphenoid. A lot of your hard palate and your facial bones actually articulate with that sphenoid also. So if sphenoid gets into a dysfunctional pattern, then the whole cranium will likely be dysfunctional. Another piece that I think a lot of therapists really miss out on, whether you're a cranial therapist or not, is the hard palate and the soft tissue that's underneath the tongue. And I really wanted to hit this home because this is so important, because everyone gets dental work. This is our avenue of expression. This is where we eat. This is where we breathe. This is where we love. This is where we communicate. We nourish ourselves with our avenue of expression. So looking at the hard palate itself is made up of 4 bones, 2 on each side of your maxilla and your palatine. So the palatine is that purple colored bone. There's a lot of cranial nerves that exit through there. There's a lot of foramen. So if you're talking about trigeminal neuralgia, that might be a big area. Another thought is kids who suck their thumb. They may be doing it for sensory input, but they also may be doing their cranial work. They may be trying to disimpact that hard palate off the sphenoid because of there's so much compression there, either from birth trauma, or maybe they had a blow to their face at some point in infancy. If you go further back, and on top of that maxilla, you have your vomer. So that's the picture directly below. And I wanted to point out this tongue and groove connection of the vomer onto the sphenoid. So if you're talking about deviated septums, you're talking about people with sleep apnea or teeth grinders, these people are looking for an airway while they're sleeping, and they're grinding their teeth to try to open their airway. So if it's something as simple as there's a dysfunction here at the vomer to the sphenoid, or the sphenoid's in a goofy position, maybe this would be something that would be very light touch and non-invasive to try before going to have a deviated septum surgery, or, working the hard palate position as it lines up with the mandible before having a sinus scraped. Or if they're having some TMJ issues, maybe try 3 or 4 sessions of cranial before having something really invasive surgically done. Also, going down to look here at this hyoid bone, which is a horseshoe-shaped bone that sits underneath the jaw. It's a sesamoid. It's a floating bone, and its main job is muscle attachment. My favorite thing to work on probably in the whole world is this complex. So if you look at this group that comes down from underneath the tongue, that's the suprahyoid group. You have a second group called the retrohyoid that moves posterior to the upper cervicals and the cranial base. A third group comes off of that down to the neck, chest, scapula, clavicle area. If you're talking about people who have things like upper cervical pain, maybe consider treating them underneath their tongue, because of that junction between the upper cervicals to hyoid to underneath the tongue. I can give you a quick little case report. I was working on a collegiate golfer who was having a really hard time with her neck position with putting, which requires cervical flexion plus rotation to look at where she's going to putt the ball. So we treated her underneath her tongue. Not only did we get her cervical range back pain-free, but she had a huge response with her airway. Not only, she had never been able to breathe out her nose her entire life. Just by working this small connection here, completely changed the characteristic of her hard palate and her nasal airway. The teeth are also important. You could treat individual teeth with cranial. You think about how many of your clients come in that have dental implants. They have permanent bridges. I have a lot of Amish that actually come in, and I'm not really sure culturally why, but a lot of the women have their teeth removed at around the age of 14. And there's a lot of dentures in that community, and there's a lot of just poor mouth care in general. And treating their hard palate, working that hard palate off sphenoid and working their tongue gives them a lot of relief with back pain and some other pathology. The last piece that I want to talk about with the tongue is if you look at Anatomy Trains, the book by Thomas Meyer, there's a fascial line that goes from the tongue and it goes down the anterior side of the spine. If you have non-responsive disc pathologies, you've tried McKinsey extensions, you've tried your traditional chiropractic care, you've tried PT, and they're just not improving, please go and treat them in the mouth. I've had 3 very distinct cases where I treated underneath the tongue and it eliminated their disc pathology symptoms. Yes, they probably still need to do some McKinseys and they still need to do some therapeutic exercise in order to prevent further reoccurrence of that disc. But it was the fascial line up to the mouth that was the keystone for them. Taking just a quick look at the TMJ, I know we've already talked about that a little bit, but it's more of this articular disc. And knowing that it's there and it's actually being controlled by the pterygoid and in some instances part of the masseter muscle, and looking at everything that articulates with and could be involved with this TMJ. TMJ isn't so straightforward. When you look at it from a cranial sacral therapy perspective, is the temporal bone impacted? Is it not flaring? Does it not have full flexion extension when you're talking about its range of motion, because that's where that mandible is articulating? Then you go down to look at the teeth connection. Do they have a crossbite? Is it a crossbite because the maxilla, that hard palate, is in a goofy position, or is the jaw physically shifted to one side? Talking about airway and those teeth grinders again. Are they grinding their teeth and they're chewing up their TMJ because they don't have a great airway? So then you could even go up to the orbit, the nasal bone, and really looking at all of those sinus pathways of the non-physiological system onto the physiological system and see what the bigger picture is. Looking inside of the skull now, we're going to move on to the meninges. Your meninges is the surrounding of your central nervous system. And this surrounds not only just your brain, but it surrounds your spinal cord all the way down to your coccyx, which is the very tip of your tailbone. We're going to call it the dura mater for the rest of the course. So if I say something like the meninges or the dura mater, this is what I'm referring to. It's in 3 layers. The dura mater is the outside. You can say that's the mother layer. Arachnoid is like a spider web. It has these pillars in it called trabeculae, and they're doing a lot more research on that now. If you check out the book Brain Stars, it talks a lot about the glial interface with the trabeculae, and it's really interesting. Then you have the subarachnoid space, is where the cerebral spinal fluid actually flows. And then you have your pia mater, which attaches directly to the brain. So that dura mater blends into those cranial bones and the pia mater attaches to the brain. So again, this is why cranial is what it is. And you're using these skull plates as handles to manipulate the nervous system. And it's through this dura mater down to the pia mater that attaches on the brain. You also have tissue called the intracranial membrane, and that's the meninges is folded in on itself. So it's a double layer. And at the end of that double layer, it creates like a vein, which we call a sinus. And that's where blood flows return to the heart, and it exits through the jugular foramen. So Danny, if you want to switch to my screen. This is the intracranial membrane. It comes out. The brain hemispheres sit around this. The edge of this has blood return to the brain, to the heart. So by pulling on a cranial bone, say I'm pulling on the parietal bone, I can actually manipulate this intracranial membrane, or I can pull on the ears and manipulate this intracranial membrane. This front part actually attaches to sphenoid, so you could do rotation, flexion, extension. And this bottom part attaches to the occiput. So by doing an occiput maneuver, you can actually manipulate foramen magnum all the way down the spinal cord. Same thing here. So if I'm doing a lift at parietal, now I have a full connection all the way down to the coccyx just by lifting on parietal because of this tissue. You can switch back to the PowerPoint. So here's another picture of it showing you where these sinuses would be located. If you feel on the back of your head, right at your nuchal line, that pointy part in the back of your skull, that's where your convergence of sinus is when you're talking about where all of this blood flow comes together. So there is a bony landmark. You can find that if you have a dog. Dogs have a huge one in the back. And it comes around and it drains out jugular foramen. And I'm going to show you a better picture of jugular foramen. I also wanted you to see what this tentorium cerebelli, this is the more lateral piece. All the cranial nerves for your eyes, except for optic, travel through this piece of tissue. So if you're talking about individuals that have a lot of vision changes, whether it's a traumatic brain injury, or you have a client who's cross-eyed, maybe they have nystagmus, this is an area that you should be more in tune with, that they don't have a restriction somewhere within that tentorium or the bones that attach to the tentorium. And maybe that's giving them some restriction and it's occluding those nerves, or it's pulling it, making it dysfunctional. Here's another picture of giving you a better visual of how that intracranial membrane goes all the way down to the coccyx. And other places where that dura mater, or that meninges, blends into the periosteum of the bone. So it's the cranial bones, like we've already talked about, that physiological system, the foramen magnum, so the actual hole where your spinal cord leaves your brain, C2 and C3. So C2 and C3 make really great handles too, as does S2, which makes the sacrum a really great handle. It also blends into the coccyx. There's also dural sleeves that extend off of all your nerve roots and all of your cranial nerves. So when someone's on the table, and let's say we're doing a parietal lift, we're lifting the top of the head, and they start to get numbness and tingling in a toe. This is an explanation of how you can use cranial to treat anything, because there is that consistent tissue that's going all the way down to the nerve that would innervate the great toe. And this goes for anything. If you're talking about, maybe you're treating a traumatic brain injury and all of a sudden they lose control of their eyelids and they're fluttering uncontrollably, or they start to posture on the table, that's because of this. You have control of this continuous sheet of tissue and you're treating the nervous system. I find this super fascinating when you talk about cranial work, and this is a great explanation for why this is a slow, steady, very light touch. For some people, it maybe even be boring with how slow it is. Because the system is collagen dominant. You're talking about fascia. This is a type of fascia. If you look at the model above, it's called the biotensegrity model. So we'll use that as an example. The wooden sticks would be representation of collagen. The rubber bands would be a representation of elastin. And then this whole system is bathed in water. Collagen is, it's stiff. It gives structure to tissue. It's three-dimensional. And it reacts to slow, steady force. You cannot force collagen to change without being really patient with it and doing slow, steady maneuvers. Whereas your elastin is what's going to react to those quicker forces. Water is what gives it hydration. It brings in nutrition. It hydrates the tissue. It gets rid of cell waste. It's also a conductor of electricity, and that's why it's also known as the primitive nervous system. If you watch later the YouTube video Strolling Under the Skin, you can actually see water droplets rolling down this system. You can see blood vessels and nervous tissue innervating this ground substance matrix, this collagen, this biotensegrity model. It's really very fascinating. But just remember that this is a slow, steady, moving modality because it's collagen dominant, and that's how collagen will be manipulated. You also have to understand that because this is three-dimensional, you cannot treat it with compression alone. This is not massage. You're not doing strokes. You are manipulating tissue in a triplanar position. You're adding a flexion, extension, a side bend, a rotation, sometimes a shear, in order to load this system so that you get tissue response. Here's a look inside the skull or inside the brain at the ventricular system. It's a hollow area inside of the brain that's full of cerebral spinal fluid. What we're really going to focus on is the fourth ventricle, and it's down there by the brainstem. And Danny, if you want to switch back to my screen. This gold piece would be representation of that ventricular system. Look how close it sits to the brainstem. It is actually part of the brainstem. So if you were to move this guy out of the way, you can see that there's a triangular piece of tissue that ventricular makes up and part of the brainstem. There's even some cranial nerves that will enter into this space, which is kind of interesting. And Danny, you can switch back. But talking about, this is where the cranial system really comes to life, is at that fourth ventricle. Because fourth ventricle is where cerebral spinal fluid is primarily made. There's a stretch receptor that runs up to the sagittal suture between the two parietal bones. So if you touch the top of your head and try to walk your fingers across to feel that suture line between your two big hemispheres on top of your head, that's your sagittal suture. So if you can, in your mind's eye, picture this little tiny stretch receptor inside that sagittal suture. So as fourth ventricle is making fluid, the cranium is literally expanding. That suture line will gap to a certain extent and activate this stretch receptor. And the stretch receptor gets signaled, and it sends a message down to fourth ventricle and says, stop making fluid. On the other side of it, you have a constant reabsorption rate through these little villi that are all along the central nervous system, along that intracranial membrane, that reabsorbs fluid at a consistent rate. So if you could picture a bathtub with a shower head. The shower head is your fourth ventricle. Your little villi are the drain. Picture you got like a washcloth shoved in the drain, and there's a constant drip coming out that drain. So as the level of water in the bathtub starts to drop, it's going to signal fourth ventricle or the shower head to turn on. So the shower head turns on, and it brings the level of the bathtub back up. But you have that constant reabsorption rate, so now the bathtub's going to start to drop. And that's that continuous cycle about every 3 seconds. This top picture in the corner is an upledger technique called a CV4, cranial vault hold number 4. This is really the closest you can get to that fourth ventricle, and in trying to encourage that system to really turn off. You're trying to reboot the system. You're trying to get fourth ventricle to stop making fluid and have a reboot. This is a really good way to start or end a session. I've seen places in books where it says you can lower fever by inducing a still point or stopping the system briefly. It will turn back on its own. It's a good way to calm somebody who's coming in maybe for their first session. They've never really had cranial work done before and they're nervous about it. But that's just kind of showing you that's really kind of where the magic happens, is at that fourth ventricle. And this is, again, talking about that filling and emptying, using the bathtub as an example. The fill is called flexion. Danny, if you want to switch back to my screen. So if you're talking about flexion, this would be sphenoid, this would be occiput. So sphenoid, remember, is where all the cranial bones of the physiological system touch this orange bone in some way, shape, or form. This is the king of the cranial system. This is vomer, kind of ignore that guy. In flexion, in that filling phase, think of the cranial system opening like a clamshell. This is called the sphenobasilar junction, where these come together. An extension occurs at that when that bathtub drain has that constant drip, or that villi has a constant reabsorption rate. And we're going to go into more of an extension or an emptying phase. So we've got flexion and extension. There's also a thought that this is the back of your throat, kind of close behind your soft palate, that maybe respiratory rate has an influence on the cranial system because there's a pressure change here with inhale, exhale. So I think some of the people that are a little bit more skeptical about cranial work, that would be their explanation for what causes the flexion and the extension, would be respiratory inhalation, exhalation. I'm more of on board with the ventricular system is the one that's creating the rhythm. You can switch back, Danny. When you're talking about rate, so it's about a 3-second fill, 3-second empty. And this is a really good way to gauge what the cranial system is doing, especially for a beginner. I don't really use this so much anymore. But if you look at the cranial system from left to right, or left lobe to right lobe, left hemisphere to right hemisphere, are things going into flexion extension symmetrically? Is the quality there? Is it very smooth, fill and empty? Is it robust? Do you have a full 3-second fill, a full 3-second empty? And then the rate is at 3 and 3. So again, this is kind of what I just showed you, that flexion extension at that sphenobasilar junction, and how, because we're talking about that dural attachment, if there's a change within that dural system, you're going to be able to feel that flexion extension, not only on the cranium, but at each spinous process. You're going to be able to feel it all the way down to the sacrum, the coccyx. And because there's a pressure change on the brain itself, especially when you're talking about the cerebellum and the cortex, if there's a pressure change there, it's not so far-fetched to believe that you could feel the cranial rhythm anywhere. You could feel it on a finger. You could feel it on an arm. You could feel it on an ankle. Here's another look at flexion extension. Danny, if you want to switch back to my screen, I've got another model. So if you're looking at the cranium, I put a model. So if I create a flexion mechanism at the sphenobasilar junction, it's going to cause temporal bone to roll forward and flare. The parietal bones will spread for flexion. The frontal bone will mimic what sphenoid does. It should roll forward with sphenoid. I think my balloon deflated. Hard palate should expand with flexion, and vomer will drop forward. So as a cranial therapist, your hands are on this skull, and you're feeling all of these positions. You're looking for something dysfunctional, something that's not rolling into flexion, or something that's not rolling into extension. And you can switch back, Danny. I really like this slide because it shows kind of the really cool part about palpation, and you can really train your hands to feel some very small nanometer movement. If you look at the black and white picture to the left, the index finger is on the greater wing of sphenoid. The thumb is on a parietal, maybe it's on sagittal suture. The middle finger is on temporal bone. The ring finger is on the mastoid, which is going to monitor the flare of the temporal bone, and the pinky's on occiput. So a cranial therapist that could monitor all of those positions and identify what's going into a dysfunctional pattern is going to have a much bigger treatment response than a cranial therapist that would just monitor sphenoid independently or just monitor occiput independently. It's being able to line those sutures up and seeing where the dysfunction is, where the fulcrum is, where the force vector is based on those movement patterns. Let's say that person's left hand is on 5 totally different structures. So if this therapist could line up dysfunctionally 5, 6, 9, 10 different structures at one time, they're going to have a much bigger treatment response than just one. The other piece, and this is where I may lose some of you, is looking and having an intent and having the ability to feel a deeper structure. So it may seem far-fetched that I could say I could evaluate the brainstem, and if it's in a torsion or a flexion or a side bend, because I can't really touch the brainstem, but I can touch the tissue that's touching the brainstem, if that makes sense. So using the ear as a landmark, that middle ear is going to be on brainstem and most likely right over the pons. If I touched above the ear, now I'm in limbic system or mammalian brain. If I touched in front of the ear, that's forebrain. And if I touch behind the ear, that's hindbrain. And that's where your education and your knowledge of anatomy will continue to grow, and you don't ever stop learning. There's so much going on in such a small area. So being able to stack not only maybe a cranial bone that you're using as a handle, but maybe now you're stacking a deeper structure like a ventricular system, or you're stacking a brainstem, or you're stacking a cranial nerve into those positions to get a bigger tissue response. And that takes us to a concept that you should be able to take to any type of body work, any type of maneuver. Nothing is ever in one plane when you're treating someone. There's at least a triplanar positioning. So if you think about a chiropractor who's wants to manipulate a specific joint, they load that joint to the max in range before they do their maneuver to push that joint. They're doing a flexion or an extension plus a side bend plus a torsion. They may even be adding some shear before they manipulate that joint. It's the same concept with cranial, but you're doing it very light touch, and you're taking it into the indirect or the position of ease before you treat into the restriction. So if you look at the picture to the left, they're showing you a spheno-basilar junction where the sphenoid meets the occiput. And that sphenoid, it looks to me like it's in neutral. Let's pretend it's in flexion. Now they're adding a rotation, a left rotation of the sphenoid on the occiput. You could take it further than that. You could take it to a flexion plus a left rotation plus a left side bend. And then you could even shear that sphenoid off of the occiput into an indirect position. The cranial therapists, in my opinion, that are really fantastic clinicians are doing this on multiple bones or multiple structures at one time. So they may be holding a sphenoid in a triplanar position, but they're also disimpacting a temporal bone that has lost its flare. They're also have a finger on maybe the maxilla, and the maxilla is in a triplanar position. They're also tractioning a jaw. So they're doing multiple things at one time to line up these force vectors in the indirect and then into the direct. I made this slide look too full on purpose. knowledge of anatomy and a knowledge of cranial nerves is key for cranial work, especially if you're going to be working with individuals who have a traumatic brain injury, if you're working with migraines. Migraines aren't just migraines. There's a lot of other symptoms that go along with those. Have they lost a nasal airway? Do they have eye tearing? Where's the pressure in their head? Do they have throbbing headaches versus stabbing headaches? Because you're talking about cranial nerve symptoms. If you look at the first four, looking at how sphenoid is involved with those first four. So if you have someone who's coming in that's got a lot of eye tracking issues, they're having accommodation issues, maybe sphenoid is a great place to start, and making sure that sphenoid isn't in a torsion or a side bend or a combination of those, and making sure that that position of the sphenoid isn't creating a tension pull onto those cranial nerves, giving you symptoms. Trigeminal is really interesting because it's such a huge nerve. There's 3 branches, V1, V2, and V3. When you're talking about trigeminal neuralgia, that's an easy way for me to see where on that trigeminal nerve path is the dysfunction likely held. Because if you have, let's say it's trigeminal neuralgia just in the mandible, well, you can trace that back to where does it exit through the cranium. But if it's involving the upper and lower part of the mouth, and maybe they're having eye tearing also, well, that's all 3 branches. So you need to trace it back further to the brainstem to see where that trigeminal nerve is on tension or dysfunctional. Another really cool piece about trigeminal is that meningeal branch that actually comes off of V2. If you have a client who comes in that says something like, my brain hurts, I don't have a headache, my brain hurts. I've also had it described as boiling water being poured on their brain. Something's crawling in my brain. Like it's a sensory nerve. It's not a headache. It's not pressure in the head. So that should tell you that trigeminal nerve is likely involved. Another one you could look at is petrous ridge. Let me find a good model for a petrous ridge. Danny, if you want to switch back to the other video. Petrous ridge holds the inner ear. So this is petrous ridge inside of the cranium. A lot of these places are the nerves that say that they are involved with petrous ridge. They sit on the petrous ridge, not necessarily going into it. So you could think about temporal bones still being a big factor with any of those cranial nerves that touch petrous ridge. You can switch back, Danny. The last one would be jugular foramen. So you can look at 9, 10, and 11. These are your whiplash injuries. That's also where that sinus drains that we talked about earlier off of the intracranial membrane. So they're going to have throbbing headaches. It's going to most likely be in the back of their head. They're also probably going to have some form of change in swallowing. Maybe there's certain kinds of foods they have a hard time swallowing. They're more likely to choke on their food. Accessory would be neck pain, or they're having challenges with certain movements such as rotation or shoulder shrugging. And then vagus nerve. That's your wandering nerve. It feeds a lot of your visceral structures. So if they're having changes in gut health after a whiplash injury, this is an area that needs to be addressed. That temporal bone on the occiput, gapping that suture line to open up that foramen. Let me see if there's any other big ones that jump out. Probably the last thing I would talk about would be the orbit. There's 8 bones that make up the orbit, especially if you're talking about traumatic brain injury again. Maybe they got hit in the face with a baseball or a soccer ball, or they hit their head off their dashboard, whatever it is. There's a ton of cranial nerves that pass into the orbit itself, above the orbit, like the part of the trigeminal nerve goes above the orbit. So looking at the lacrimal bone itself, are they having eye tearing? That could be trigeminal, or it could be another cranial nerve. Is their airway changed because that sinus sits right under the orbit? So it's a pretty comprehensive list, and it's something that you could keep revisiting. Here's a picture of that jugular foramen exiting the skull between the temporal bone and the occiput. So right here at that suture line, there's a pretty substantial size foramen where those 3 cranial nerves exit your jugular vein. And like I said before, you're looking at a lot of whiplash type injury here. Oh, I skipped one. We're not going to go over polyvagal theory. Even if you have a question about polyvagal theory, I'm not going to answer it because that's you could spend an entire lifetime on polyvagal theory. My point with this slide is looking at the vagus nerve as it exits that jugular foramen, and look at how long it is and how much visceral structure it actually innervates. So if maybe you have someone who's come in that's been in a car accident, now they're having heart palpitations. It could be a vagal nerve dysfunction, or it's being impinged in that small foramen. Maybe they've got gut changes. Now they have more diarrhea than they did before. Now all of a sudden they have IBS, or they have constipation, or whatever it may be. Maybe they're more anxious. So this vagus nerve is a huge thing that needs to be looked at. This is the gut-brain axis. I just throw this in there because you're not only supporting the top end with cranial, but you need to be supporting the bottom end, meaning the gut structures and the sacrum. So if you look at the celiac ganglion, which is this first one, and then you have your superior mesenteric ganglion, these are directly vagal nerve. There's no synapses. This is actually your brain and your gut. That's kind of a crazy concept to think about, that my brain is in my abdomen. There's a lot of nerve connection going on, and there's a ton of lymphatic tissue. It would behoove you to do some work here, to get some more knowledge here, maybe take some visceral courses, maybe take some lymphatic courses, because you need to be able to not only support the top end when you're talking about cranial sacral work, but also the bottom end. I get asked all the time, what would cranial do for me? Well, you're working on the central nervous system, and the central nervous system literally controls everything. So really you could treat anything with cranial. But there are very specific things that people come in for. The most common for me would be headache, migraine, TMJ dysfunction, trigeminal neuralgia, traumatic brain injury. I've treated a few kids with ADD, ADHD. I haven't had the opportunity to treat a lot of autistic individuals. I've had quite a bit of success with tinnitus. Nystagmus, we've had pretty good success with. If you're looking at child or pediatric disorders, misshapen head, those need multiple sessions very close together. Torticollis is a big one. Sometimes torticollis is also viscerally based. They have more of a pull in their abdomen, and it's pulling that central nervous system. So that's something to be conscious of. I have treated juvenile rheumatoid arthritis. That's more of quality of life rather than finding a permanent solution. Let's see. I've treated Bell's palsy, but not cerebral palsy. I've seen quite a few forcip and vacuum babies. I treated a child who was transverse, and she had a variety of other issues. If you look at things like C-section versus natural birth, a lot of times they'll have chronic ear infections. So that's something else that you could look at. But that's a pretty short list. I won't spend a ton of time here. I just wanted you guys to know that this is a thing, and there's a whole world of education out there if this is something that you're interested in. Retained primitive nerve reflexes come with a lot of other challenges than just physical or neurological developmental things. So if you're looking at an infant who is born with these 10 or so reflexes, they're designed to help the nervous system develop and hit these milestones such as rolling, to sitting, to crawling, to standing, to walking. Walking will precede talking. When these benchmarks aren't necessarily hit on time, these reflexes don't get integrated. And what I mean by don't get integrated, they live in the brainstem. These nerve reflexes need to be, for lack of a better term, pruned, and a bigger nerve connection needs to be laid down to a higher brain center, being mammalian brain or the neocortex. So if you have an individual who comes in that is really stuck in these primitive nerve reflexes, they cannot reciprocate. Their pelvis will not reciprocate. They have the inability to roll, and they won't move on to things like crawling, or they won't walk as smoothly. Then walking will precede talking, and they'll miss these bigger neurological landmarks. So when my pediatric kids come in, I test them every single time. These nerve reflexes will not show up independently. They will show up in gangs, usually 3 or more. I can give you a quick overview. My son was having a lot of challenges with meltdowns. He would be very sensitive to sound to the point of going into fight or flight. He was having a really hard time potty training. And I was kind of at my wit's end, and I stumbled across this and took a couple really small courses on it and learned the integration exercises. And we saw a huge change within only a few weeks. The meltdown started. Potty training was smoother. He was no longer went into fight or flight with certain sounds because we were moving past that reptilian brain and moving to a higher brain center. We were laying down bigger nerve connections so that he could develop. And that whole thing, I found out that my Moro reflex was not integrated, which opens a whole new door to treating adults with these really neuroplasticity exercises that are made for kids. A lot of these reflexes will develop into learning disabilities if they are not integrated. There's actually, if you went on PubMed and just Google and searched primitive reflexes, you'll see it's really, to me, a big study that came out and where they went through a preschool and they evaluated the majority of the kids in that class. And there was a huge percentage of them who were not integrated. So you're going to see ADD or ADHD type symptoms popping up. You're going to see poor handwriting. You're going to see really challenging behaviors in the classroom when you could be doing some of this integration with cranial work and educating parents on these really simple integration exercises. I probably didn't do this slide justice, but just so it gives you another rabbit hole to go down. Some contraindications for cranial work, anything with a bleed. So if you're talking about traumatic brain injury, make sure that they're out of the acute stage and that they've been cleared by a physician before moving forward with that. Aneurysm, if someone has an active aneurysm, they're going to be in the emergency room or passed out. So you're not really having anything to worry about there. Some precautions. They're all dural tube work for the most part. I've never treated someone with spina bifida. I did have someone disclose they had a closed spina bifida, and I chose to refer them to somebody else. Down syndrome, they have a weakened alar ligament. Those are the suspensory ligaments that help stabilize the skull on the atlas axis. So be careful with those individuals. Herniated medulla, I have treated that before. We just didn't do any cranial base releases with them. We saw some pretty big changes with that individual. Acute fracture, specifically C1, C2, but really any fracture of the skull, make sure that it's an old fracture and that it's healed. And then children and infants don't have a lot of the bony landmarks that adults do. So they have a few precautions as well. Here are some easy books to get you started. Inner Physician in You has a lot of casework, case studies by John Upledger. Some of them are pretty wild and hard to believe, but I've seen some pretty wild stuff happen on the table too. Cranial 1 and Cranial 2 are also written by John Upledger. The Cranial 2 book probably has the most anatomy and physiology. That's a great one. Soul of Discipline is more for pediatric treating, and it talks about neurodevelopment and hitting landmarks or benchmarks. Energy Medicine, it looks at the physics side of body work from an energy standpoint. And here's a documentary you might want to check out. It used to be on Netflix. I don't think it is anymore. But it goes through a lot of different body work that's very similar to cranial work, or that you could use as an adjunct to cranial work. And it also has a very short section that explains energy work from quantum physics. And I would never do it justice, so that's why I put it in here if that's something that you wanted to check out. And we're not going to go over somato-emotional release. It's too involved. I think if you just, and I think everyone would recognize this at this point, that you can't separate the emotional and the spiritual side of a person out. It can't be dissected out. It's part of body work. It's a part of medicine. It's a part of being a human. And there's a lot of emotions that's going to come up on the table with cranial work. And because you're on the nervous system. So just being able to refer out for counseling if that does come up on the table, or maybe have a little bit of dialoguing skill so that if it does come up, you can at least get them safely off the table and to a counselor. Here's some treatment concepts, just going over them really quick. We briefly talked about indirect direct, and we're talking about triplanar positioning. Cranial work and a lot of other body work, you treat into the position of ease to dampen the central nervous system response, so that when you move into that restricted segment, there's not as much fight from the body, and it's easily moved through with cranial because it's so light touch and it's very gentle. It's client driven. It's not clinician driven. Removal of bias is probably the hardest part for me. Learning cranial, because number one, I had a skepticism coming from sports medicine, and that everything was evidence-based, and that you really looked at the history of the person you were working with. Whereas with cranial work, you really have to trust your hands and what your hands are telling you. So coming from Division I athletics, where I knew my athletes inside and out, and I knew, sometimes I felt like I knew their history better than they did, trying to eliminate that 100% and then trust what my hands were telling me. Why am I treating a temporal bone when they're having right shoulder pain? That doesn't make any sense until I started to dive into the anatomy and the physiology and understanding that connection. A lot of times I will even evaluate the person with my hands before I do a full intake with them, just so that I know that I can trust what my hands were telling me and not letting my brain take over. Staying grounded, having your feet literally on the ground, not taking on any garbage or baggage that the person on the table has, and you're not giving them any of yours. Setting up a wall. Early on, I would do this affirmation a lot. I don't have to do it that much anymore. I think my inner being just kind of goes there. What is mine is mine. What is yours is yours. It puts up that wall. There's not going to be an exchange of baggage. I certainly don't want to give my clients stuff that I'm dealing with at home or out in the world. So same thing. Working at 5 grams at the tissue level. I think this is where a lot of people get lost with cranial. Cranial is so light touch, and it almost doesn't make sense how it works so well being so light touch, even when you talk about the ground substance matrix. It's 5 grams at the tissue level you're working. So we talked about that continuous tissue going from the cranium all the way to the coccyx, or covering a nerve root and could potentially go all the way down to your big toe, or doing a deeper structure within the skull. So I may be light-handed at the beginning, but by the end of the session, I may be fairly heavy-handed on this individual, maybe because I'm down to brainstem level, or maybe I'm all the way down to L5 and I'm doing some traction work down to L5. So it can get fairly heavy-handed. You know, there are a lot of therapists that stay at 5 grams at the surface. I tend to get heavier as the work goes on. And then the last piece that's hard for people to, I think, to take on is intent. My intent for them is to treat them where they take me in the indirect direct model and to have tissue change. Is it so far-fetched for me to say that my intent is to feel the cranial system? Is my intent to feel the lymphatic flow? My intent is to feel visceral movements? Is my intent for you to get better? So if you went to a PT session and that PT's intent was for you to not get better, or for your pain to not improve, for your range of motion to stay as is, do you really think that your sessions would be productive? They probably wouldn't be. So having an intent and having a picture in your mind's eye of what you're treating, I think is a big key factor in treating with cranial. And you look for your tissue release signs to know that you can move on. The biggest of all of those is probably viscous compliance. If you have ever tried to pull a full trash bag out of a trash can, it's impossible unless you grab the can with your feet, right? So that feeling of pulling that trash bag out and you're holding the can with your feet, and right when that trash bag comes, that's what viscous compliance feels like. When you're using that cranial bone as a handle and all of a sudden the handle comes toward you, you know that you've gotten viscous compliance at that suture line. If you're still on the fence about cranial, you're not sure you want to go down this rabbit hole, I would really encourage you to go get treatment by a variety of cranial therapists. I am totally different than how my mentor treats. I'm totally different than how the therapist down the street treats. I have a staff member who's diving into cranial work, and we are 100% different in our touch. Our frequencies are different. Our tempos are different. Our knowledge base is different. So just because you had a bad experience with one therapist, don't write the therapy off. Maybe try 2 or 3 more. There's a big skill set out there. The Upledger Institute has tons of case studies and journal review articles available. I have a short resources page on my website. And that's kind of it. Perfect. Thanks for coming.